All right, one of the reasons that we love doing Scan FYI is that we get to feature all kinds of different resources, doctors, all kinds of things about Monmouth and Ocean County that your average person might not know about. And today we're going to talk about one of the latest innovations in cancer care, immunotherapy. I'm guessing if you're like me, you've heard it, but you don't know what it is. So we're going to find out today. So if you want to know what immunotherapy is, stay tuned. Good morning, everyone, and welcome to Scan FYI. My guest this morning is Dr. Seth Cohen. Good morning, Dr. Cohen, and thanks for being with me.
Good morning. Pleasure being here.
So rather than you are the Director of Oncology Services for the Barnabas Health Southern Region, but why don't you share with everyone listening a little bit about yourself and exactly what you're doing?
Sure. Thank you for your time. I appreciate everyone listening in today for this hopefully informative discussion about cancer care and updates of cancer modalities. My name is Dr. Seth Cohen. I am a medical oncologist. I've been in practice now for 20 years in Monmouth and Ocean County. As the director of our facilities and centers, I'm in charge of the growth and innovation of our cancer care treatments. I run approximately 60 clinical trials locally, and one of my focuses is bringing in new cancer care and research into the region, so we have local care for our patients and excellent care that could exceed and get an excellent outcome for all our loved ones near us.
Well, of course, I love that you're talking about local care because that's important. This is where we live, and ideally, this is where you get your care. But let's first talk about just give a brief explanation. What is a medical oncologist, just in case someone listening doesn't even know what that means?
So a medical oncologist is someone who I hope is board certified in medical oncology. That means they did medical school, 3 years of likely internal medicine residency, and then 3 years of specialty in an oncology fellowship, followed by a board certification. And then they have the ability to specialize in treating with oncological agents. So for instance, you may know someone who has breast cancer, lung cancer, colon cancer, rectal cancer, pancreatic cancer, any different cancers that a person may have. We have the ability to not only give chemotherapy, but also to monitor and observe patients to really, I actually deem the oncologist as the quarterback of the team, and we coordinate between our surgical oncologists, specialists who do surgery for the patients, as well as our radiation oncologists and other modalities that may be necessary for a patient's care. We are the quarterback in charge of that person's care overall from a cancer diagnosis. So anytime you hear the word cancer diagnosis, usually that should mean an oncologist will be involved. Obviously, there are some cancers that an oncologist does not need to be involved, depending on what that cancer is. But in majority of cancers, you would want an oncologist being on your side, advocating for you, treating you, monitoring you, following up with you, and at times, obviously, caring for you for treating your underlying disease process.
Okay, well, thank you for explaining that so well for us. So I think most people are probably like me in that when you hear about cancer, whether it's for you or for a loved one, we immediately think about, well, there's going to be chemotherapy or there's going to be radiation therapy or some kind of a combination. But there are new treatments. And that's what we want to talk about today, specifically immunotherapy, because again, if you're like me out there, you might have heard it, but you don't know what it is. So let's get into that.
Great. I think immunotherapy has really been one of the inflection points in cancer care. Immunotherapy is essentially harnessing one's immune system, in specific their T cells, to fight against the cancer. So it usually involves an infusion of therapy. I'm not going to use the word chemotherapy. It's an infusion of immunotherapy. The platform that's used for fancy terms, if people want to Google it, it's called PD-L1. And different patients respond differently to immunotherapies. I'll give you an example here. There is a patient I saw few months ago who came to me with a newly diagnosed rectal cancer. And they said, Dr. Cohen, I don't want to go through surgery, radiation, chemotherapy. And I said, well, that is one possibility, but let's check for a certain protein to see if you have what's called microsatellite instability and a gene related to something called Lynch syndrome, which is the genetic form of colon cancer. She happened to have it. Knowing that she had that gene allowed her, and to be clear with our audience, only 5% of people essentially have that protein.
Wow.
She only needed 9 doses of immunotherapy, and now she is cured of her cancer. After the second dose, the tumor melted away, and she knew that because she wasn't able to have a normal bowel movement. She was bleeding. By the third dose, we knew she was cured. She got the standard 9 doses of therapy. She had statistically what is published 100% response rate with 100% cure rate, which is unheard of 10 years ago. And on top of that unheard ofness is that this is a patient who really can go to work every day, had some fatigue. There are some side effects from immunotherapy. To be clear, it's not like you come in on Monday, you get your treatment, and then that's it.
Right.
But after 9 treatments, she is cured and she is doing great. She saw her surgeon who's not so familiar with immunotherapy, and I have to educate not only my lay people, but also my surgical people in the community that do not touch this person. She is cured. She is going to do great. She looks great. And that is just a single doses of immunotherapy, no chemotherapy, no radiation therapy, no surgery. So those are specific home runs we have with immunotherapy. Not all
That's
immunotherapy.
Remarkable, by the way, remarkable. Wow. Yeah.
It is. Not all immunotherapies are home runs. Not all immunotherapies treat this way, but when you hit a home run, you really hit a home run. I mean, it's a grand slam for this patient because this patient is clearly responding. But we have similar stories in each oncological disease we have. For melanoma, that's when immunotherapy actually got its head start because melanoma is an immunologically mediated disease. In the olden days, there was only one drug. We combined it with another drug in the immunotherapy class called CTLA4. And now we have clinical trials with a third drug with melanoma that's using these drugs on a platform to prevent and treat metastatic disease. So we've transformed cancer care to fill in the gaps in not all diseases, but certainly in some diseases that were so dismal prognostically now have turned the corner to potentially curable diseases. The other paradigm is in lung cancer, for instance. Patients who were really doing poorly, now we give immunotherapy. There are patients that had metastatic, meaning disease that has spread beyond the site. For instance, the cancer went to the brain, went to the liver, went to the bones, and they have gone on both chemo and immunotherapy, not just immunotherapy alone, now have stopped their immunotherapy after 2 years and are deemed cured. There is no disease. So this is a whole different ballgame, and your audience needs to understand that not everyone could get immunotherapy, and not all immunotherapy works, but in some patients it works, and it is changing patients' quality of life, patients' expectancy of life, and it's curing some patients.
I mean, it's really awesome just to hear that, because I feel like for so many people, a cancer diagnosis is feels like a death sentence, right? For so many people, and maybe years ago it was, but obviously you're giving us tremendous hope, and obviously a lot of opportunity. So, are there any particular cancers that do especially well with immunotherapy?
So the typical immunotherapy mediated cancers now the list has grown almost beyond belief, meaning it affects lymphomas, it affects melanomas, it affects kidney cancer, bladder cancer, colon cancer, and specific Lynch type syndromes that we just discussed. It affects cervical cancer, GYN malignancies and uterine cancer. It affects lung cancer, esophageal cancer, gastric cancer. I mean, the list is so tremendous that if you look at the package insert, you almost wonder which cancer is not there. There are some cancers that are not there. Pancreatic cancer, immunotherapy is not really a standard because it doesn't affect or benefit it. But there are other targets that are being developed in each of these cancers, in addition to immunotherapies, that are also equally as effective and also could benefit patients. And there's an entity called small cell lung cancer. Small cell lung cancer is a lung cancer. More patients have the standard lung cancers, which is called adenocarcinoma or large cell lung cancers. Small cell lung cancers are super aggressive, and unfortunately, the median survival is very short if it is spread beyond the lungs. We now have a drug in second and third line therapies. We actually use immunotherapies in first line therapies, and that in itself has improved survival. But now we have another drug called the bispecific therapy, which is I call it rocket science, that we can give our patients. And one of my patients who has metastatic small cell actually has a complete remission, which is never heard of in small cell for metastatic. She had a disease that had spread to her liver, and it was a liver full of cancer, I call it. She was deteriorating pretty rapidly because that's what small cell does and happens to patients when they start doing poorly. We switched her therapy to a bispecific therapy. The drug name is Imdeltra. It just got FDA approved. It's an Amgen drug. She received a couple infusions, and you knew while she was receiving these infusions, you saw her liver function test, her jaundice go away, her bilirubin improve, her liver function test improve. And she said, we need a scan. I said, of course we need a scan, but I can tell you the scan is going to tell me exactly what we know already. You're doing great. She got a scan, and the scan shows a complete remission, which it doesn't happen in everyone, to be clear.
Of course.
Statistically, it's a small slither of the population, but we've never had a 40% response rate for third line small cell lung cancer, meaning approximately 2 in every 5 patients are responding to a drug down the road that we had 0 drugs to give to them. And the only thing we could offer those patients at that juncture was hospice. We are changing the tone. We're changing our treatments. We're improving survival, and quality of lives are getting better. And that is the take-home message for all cancer care in 2024. Things are changing so rapidly to the point that we're using monoclonal antibodies, we're using ADCs, we're using targeted therapies, all these types of drugs. We're not curing everyone. I wish to say we're there, but in order to get to a place, you have to take a journey. And the journey is finally, we're seeing some fruits of our research that have been planted for years now, and we are moving forward and improving patients' quality of life and survivals. So we have different classes of drugs. We have standard chemotherapies that a patient may still need. We have monoclonal antibodies that a patient may need, like drugs for breast cancer called Herceptin, Perjeta, and HER2. Those are drugs that are targeted against a certain protein. But then we also have monoclonal, we have ADCs, which are antibody drug conjugate drugs, which are specific to a certain type of cancer. And then we have what we've described as immunotherapy. So we have different layers and different types of therapies that we can offer patients. And all these combined now are changing how we treat our patients.
So what I want to remind everyone who's listening to this conversation with Dr. Cohen is that these therapies are available to you locally. And we had talked about that earlier. I think it's really important to have the opportunity to be close to home when you're getting these treatments. And maybe years ago you couldn't, but you can now. In Monmouth and Ocean County, you can have this right here, correct? It's available.
Correct. To me, it's amazing that I jokingly say I could treat out of a minivan if I needed to, because
good to know.
These drugs are available universally. The oncologist, this needs to be aware of them. And my practice and our affiliation with Rutgers Cancer and RWJBarnabas healthcare system, we have availability of these drugs, we have access to all these medications, and we have the ability to give them in all these locations. So there is no need, psychologically, people think they need to travel for better care.
Yes.
They actually need not to travel. They need to stay local for better care. Care gets complicated when you start traveling a long time and they're not offering you anything better, or perhaps not even the standard of care. I mean, I see now at my point in my career, I see a lot of second opinions of patients who've traveled far away for the wrong thing all along. And we know, and I know, that patients could get the best care locally with the ability of having an option of a clinical trial down the line, which opens up a whole new avenue of options for a patient.
This is all good news for anyone who, if you yourself have a cancer diagnosis or a loved one does. We're going to put all of the contact info in the description if anyone wants to reach out, if you want to share this. I just feel so fortunate to have the opportunity to share all of this information with the public, because I do feel a lot of people, you're just like me and you don't know. You might have heard the words, but you just don't know. So Dr. Cohen, thank you so much for sharing all of this. Awesome.
It's my pleasure. Our marketing department is not as good as our results.
That, I want to say, I hope I never have to see you professionally, but if I ever did, I feel like I would be very lucky to know that this was available right in my hometown. So thank you for that.
And we welcome patients into our practice at all times. We are, as a group, completely accessible. All my patients who get treated have my personal cell phone, to the detriment of my family and my family life. Just kidding.
There is no family life, right? Yeah.
But to me, it's an honor
You're
to be
very
able to
committed
treat.
to what you're doing.
Yeah, it's an honor really to treat in the community and to serve the community, and to have, every day patients will say, well, how do you do this job? Isn't it upsetting or depressing? And I say, just the opposite. Look at your results. I saw a 90-year-old lady yesterday who had metastatic bladder cancer. 5 years ago, we could not offer her anything. She's on an antibody conjugate drug with immunotherapy, and she is in a complete remission and living life beautifully. And she smiles, and she's adorable, and she's lovely. And I said, the only reason why I do what I do is I have patients like you who do so well. So.
All right. Well, you heard that from Dr. Cohen. So again, thank you so much for being with me today. Remember out there, if it's important to you, it's important to us. I'm Andrea Tarr. We'll see you next time on Scan FYI. Bye, everyone, and bye, Dr. Cohen.